So hello guys, welcome back to my channel Maniac Medico, and today we are going to discuss about adrenergic drugs. So we will finish off with CNS very soon, and then we will enter to various other subjects so that it can become easier. I'm thinking to start off with physiology. So for now, let's continue with adrenergic drugs. What are they? Where do they act? And the various examples of drug. This chapter is a bit lengthy, and many of them find it difficult too. So we'll try to simplify it and make it easier for you guys. So let's begin with adrenergic drugs. So this acts in the sympathetic part of the ANS. The ANS is divided into two parts, sympathetic and parasympathetic. The parasympathetic is responsible for increasing everything except for heart rate, and the sympathetic decreases everything except for the heart rate, right? So let's get started. So if we talk about adrenergic drug, what comes in your mind first? Adrenaline and non-adrenaline. So yes, you're right, we will discuss about catecholamines, which is adrenaline, noradrenaline, dopamine. We will see how they are synthesized, how they are stored, how they are uptaken, how they are reuptaken, and what is the mechanism of the action. So let's start with noradrenaline, right? So they are in the postganglia. They act in the postganglia except for sweat glands and vasodilating fibers, the fibers which are responsible to cause vasodilation. Decrease secretion by they're in lower quantity. They're secreted in the adrenal medulla. As we know, the adrenal medulla is neurogenic in nature, right? So from the embryonic tissue, they are neurogenic in nature, and a little quantity of them, noradrenaline, is secreted by the adrenal medulla. Most of them is secreted by the adrenergic neurons, which is present in the central nervous system, right? Next is adrenaline. It has no role in sympathetic part, that is the periphery. Peripheral neuron, there is no specific effect of adrenaline, but it has effect on various organs like heart, blood vessels, and on the liver. How it degrades the free fatty acids. We'll discuss it further. Next is dopamine. It is majorly present in the basal ganglia, limbic system, chemical trigger zone, anterior pituitary, and it has limited action in the peripheral vessels, and peripheral action especially in the renal vessels related to the kidneys. So we'll study how catecholamines are synthesized. So what happens first is phenylalanine, as you know, right? Phenylalanine. In liver, it is converted to tyrosine. Now, tyrosine can convert into various things. One of them is dopamine, the other one is melanin, right? So, tyrosine converts to dopa. Okay, so what happens is, if phenylalanine is not getting converted to tyrosine, there is a disease called as phenylketonuria, right? Which happens, phenylketonuria. So everything starts with phenylalanine converting to tyrosine. Here in phenylketonuria, tyrosine hydroxylase enzyme is absent. So phenylalanine in liver is converted to tyrosine. Tyrosine in adrenergic neuron converts to dopa. This is not dopamine, it is dopa. Dopa is in the vesicles, dopa is converted to dopamine. Dopamine in adrenal medulla converts to noradrenaline, as I told you, some quantity, and noradrenaline is converted to adrenaline. So here tyrosine hydroxylase, which is the enzyme which converts phenylalanine to tyrosine, it is the rate limiting step. So what is the rate limiting step? So from here, this enzyme decides if the reaction is going to go in the forward direction or it is going to go in the backward direction. As we study in chemistry, if the reaction is feasible or it's not feasible. So rate limiting step every time decides if the reaction is going to move in the forward side or the backward side. If I decrease the amount of tyrosine hydroxylase, the reaction won't take place at all, like if there is no enzyme over here. So it has gone into the backward direction. But if I add tyrosine hydroxylase, the reaction shifts to the forward direction. And at this point, I can change the course of the reaction. Any reaction can be changed at the rate limiting step, right? I hope that's clear. Next is storage of catecholamines. So how are they stored? Here they are synthesized through this pathway, but how are they stored now? So the storage happens, noradrenaline is stored in adrenal neuron terminals, right? So as we all know, all the neurotransmitters, it is stored in the synaptic knobs. Whenever they are required, they are pushed out for transmission. So what happens is, there's pathway how they go out also, we'll discuss about that. So what happens is, noradrenaline is present in the neuron terminal. So what happens is, it has to be stored. It cannot be in the free state moving. If it is moving, then it will cause transmission, right? It is not always that nerve transmission has to take from cell body till the, this is the dendrite, this is the cell body, and this is a synaptic knob. It is not necessary always. The reaction it has to take place from the cell body till the synaptic knob. opposite can also happen, but what happens over here is dyne takes place, dyne. So dyne is responsible to carry the electrical or the chemical signal from the synaptic knob to the cell body of the neuron. It takes place via dyne, and normally from the cell body to the synaptic knob it takes place usually, right? Over here, please remember, in physiology you might have learned via dyne this takes place, the transport. So we were with storage. So noradrenaline with ATP is always stored in the ratio of 1:4. So for every 1 noradrenaline you need 4 ATP, adenosine triphosphate, right? And it is absorbed by chromogranin. It is absorbed by chromogranin. So chromogranin is a substance present in the synaptic nerve, and this absorbs it, right? And role of catecholamines is controlled by monoamino oxidase, monoamino oxidase. So this monoamino oxidase is present on the surface of mitochondria. So what happens is they attack the catecholamines whenever they are present in the free state. We'll discuss about it, how it happens. Next is the release. There are two ways of release. One is the exocytosis, the other one is the vesicular content. So exocytosis, what happens is, if this is the synaptic knob, what happens is, suppose this pocket has noradrenaline in it, this will come attached to it, and after some time this slowly opens up and this thing comes out over here. So this is basically exocytosis, or it is how it just goes to the surface and then it comes out from there. That is exocytosis, right? Next one is the vesicular content. So vesicular content has a transporter named as VMAT. We'll discuss about that. And also neuron peptide, NPYY, NPYY2 or P1ATP. They are the different types of neuropeptide which aid the transmission, right? Which help the content to go out. Indirect acting sympathomimetics, that is tyramine and amphetamine. So these are two drugs. They're directly acting sympathomimetics, that is they mimic adrenaline and noradrenaline. So they confuse the synaptic nerve, and what do they do is they displace noradrenaline from its place. So if for some reason the patient has a shortage of noradrenaline, so we can use tyramine and amphetamine. So they displace the noradrenaline from the synaptic knob without exocytosis. So they don't use the mechanism of exocytosis, it is just displacing. So if it is at this position, they come and sit over here, this noradrenaline has to go out, this is displacement, right? And what they use is, they use the mechanism of uptake 1, which is coupled by sodium. They use sodium coupled mechanism, like how we know that in GLUT receptors, glucose always travels with sodium, right? So every glucose molecule has to travel with a sodium molecule. Similar way, they also use a sodium coupled mechanism by uptake 1. So what happens here is, we'll talk about reuptake, right? So there are two mechanisms, there are three mechanisms: axonal, vesicular and extraneuronal. But of importance is axonal and vesicular, because maximum amount of catecholamine which is reuptaken is noradrenaline itself. So what happens is, there are two steps in this. First is active amine pump, NET transporter. So what they do is, this is also called as uptake 1. They take adrenaline by sodium. So whenever the sodium molecules enter the cell surface, along with that adrenaline is pulled. So this uptake 1 is more sensitive towards adrenaline, so more of adrenaline is taken. 70 to 90% of noradrenaline which is released is taken up, then compared to adrenaline. It is not that sensitive to adrenaline. Next is vesicular uptake. So there's a pump over here, we call it as VMAT2, vesicular monoaminotransferase 2, right? So intracellular pump, it is an intracellular pump. So they take catecholamines from cytoplasm or exoplasm, call it whatever, to the vesicles. So vesicles are nothing but the small pockets which contain all this. So what they do is, they exchange an H plus ion, right? Cation exchange takes place, that is the H plus ion is taken out, and they use vesicular. So what happens over here, the vesicular noradrenaline leaks out in the exoplasm and is recaptured. So this VMAT always recaptures it. So if it has entered the axon, it starts leaking out from there. So they recapture it, exchanging it for an H plus ion, and they also take some extent of dopamine. They convert it to noradrenaline, right? So this thing is inhibited by reserpine. So reserpine is a drug which can inhibit VMAT2 or vesicular monoaminotransferase 2. The third one is extraneuronal. So what happens here is catecholamines uptake 2. This is also called as, this was uptake 1, this is called as uptake 2. So this is extraneuronal amine transferase, ENT, or OCT, organic cation transporter. OCT1 is there, OCT2 is there, there is OAT also, which is organic anion transporter. So they take adrenaline, but they don't use, this is uptake 2 is responsible for the take up of adrenaline and not noradrenaline. So we have two uptake mechanisms for noradrenaline, that is axonal and vesicular. But in extraneuronal, what happens is adrenaline is taken up. So they don't use the mechanism of sodium, that is not similar to uptake 1. Hence, it cannot be inhibited by cocaine, right? Cocaine can inhibit uptake 1. But in case of extraneuronal, this cannot be inhibited by cocaine, but the inhibitor for this is corticosterone. Corticosterone is the inhibitor. Now let's talk about the metabolism, how adrenaline is metabolized. We have synthesized it as we studied in pharmacokinetics. Every drug is absorbed, reabsorbed, distributed, and then it has to be excreted. So what happens is noradrenaline from vesicular and exoplasm is attacked by MAO. Monoamine oxidase always attacks, or it takes up. The one in the circulation is attacked by COMAT. What is COMAT? Catechol O-methyl transferase. So this is present in the liver, right? So these enzymes, they produce what? VAM, right? Vanillinic acid, VAM, and also aldehyde reductase, alcohol dehydrogenase. These are the byproducts when they are metabolized, right? And also meta and normetanephrine, these are all excreted in the urine, or 3,4-dihydroxy mandelic acid, or DOMA. So these are the chemical products which are excreted, or these can be found in the urine. So how much of this is excreted in urine? 25 to 50 μg of noradrenaline and 2 to 5 μg of adrenaline is excreted in every 24 hours. So this can be found in the urine. Now we'll discuss about how they act in various different organs. For your convenience, I have made a table. I will attach it somewhere here, and we'll discuss how they take part in various organs, right? So guys, let's continue with the receptors, their location and their various action on different organs. So let's start. There are basically alpha and beta receptors, right? So there's alpha 1 and alpha 2 mainly, and there is beta 1, beta 2 and beta 3. So they are present in various organs. So let me tell you about alpha 1. So alpha 1 is present at post junction in all organs, right? They are present post junctionally in all effector organs. And alpha 2, they are present in the pre-junction, post junction fibers in the brain, and extra junction in certain vessels, right? So this is the location of alpha 2. I will attach the table, and then let's come out the beta. This is beta 1, beta 2 and beta 3. So beta 1 is present in heart and JG cells. So we have one heart, so there is one beta, right? Then there is beta 2. Beta 2 is present in uterus, liver, bronchi and GIT. So we can remember that beta 2 is present in lungs. We have two lungs or a pair of lungs, so beta 2 is present there. And beta 3 is mainly present in adipose tissues, right? Adipose tissues and detrusor muscles. Those are the location of alpha, beta, alpha 1, alpha 2, beta 1, beta 2, beta 3 respectively. Then there is alpha. So in alpha, adrenaline is the most effective when we compare to adrenaline, noradrenaline, isoprenaline. Then compared to beta, isoprenaline is more effective, then followed by adrenaline and noradrenaline. But when we use more of adrenaline and noradrenaline. So let's see the action. Adrenaline can act on alpha 1, alpha 2, beta 1, beta 2 and weak beta 3 action. Noradrenaline acts on alpha 1, alpha 2, beta 1, beta 3 but no action on beta 2. Isoprenaline acts on beta 1, beta 2, beta 3 and it has no alpha action, so it is not of much in use, right? So let's see about the heart. What does it do to the heart? So on heart, as I told you, it's present in beta 1. Adrenaline always increases the heartbeat, right? It causes tachycardia. So systole is shortened, then diastole conduction increases, RP is abbreviated, right? RP complex is abbreviated, hence the heart rate increases. Blood vessels, so alpha and beta, there are two. Alpha causes constriction, beta causes dilation. In alpha, what happens is junction neuron causes the release of noradrenaline, and extra-junctional neuron, where the circulating catecholamines both can act on it, right? Noradrenaline and circulating catecholamines can be adrenaline, noradrenaline, and dopamine. No action on cerebral vessels. In beta, what happens is dilation, but there is no action on cerebral vessels. Adrenaline can act on arterioles and pericarpillary sphincters, but only at a higher dose they can act on larger arteries and veins. We need a high dose for them to act at larger arteries and veins. In lungs, what happens is adrenaline and isoprenema, they protect bronchodilation, so they cause bronchodilation, right? With beta 2. Rapid IV injection causes apnea or absence of breathing due to inhibition of respiratory center, right? Respiratory center is present in our hypothalamus. Next is what happens, adrenaline decongestions the mucus by alpha action, right? They decongest the mucus, hence they clear the mucus. We can use them in asthma. Directly stimulate the respiratory rate. So what happens is they directly stimulate the respiratory rate at toxic doses. What can happen is edema, pulmonary edema. What happens? That means pulmonary edema is a swelling of the lungs, right? Pulmonary edema can take place. We will learn how edema takes place, right? But later in pathophysiology. Next is blood shift from systemic to pulmonary circulation. So the blood is shifted from systemic to pulmonary circulation. Blood pressure. So there is no as such effect, right? There is no as such effect, but what happens is the heart rate has changed over here. So for tachycardia, the blood pressure also changes accordingly. So let's see what noradrenaline and adrenaline do. So noradrenaline, it increases systolic, diastolic, and mean BP. The systolic and diastolic and mean BP is increased. Why? Because of alpha action, right? The alpha action takes place over here. Adrenaline, slow IV infusion or subcutaneous injection causes increased systolic, decrease in diastolic, and overall the mean BP increases, the pulse pressure increases, right? PR over here is peripheral resistance. So PR, peripheral resistance, decreases here due to beta 2. But peripheral resistance over here is high because the mean BP is high over here. On rapid IV injection, the systolic is increased, diastolic is increased, and mean BP also increases, right? Talking about isoprenamine, what happens is systolic increases, diastolic decreases, mean BP overall decreases. Peripheral resistance will also decrease, pulse pressure will also decrease. In eye, what happens? Mydriasis happens, right? Due to iris constriction. So constriction of iris will take place, which causes mydriasis. So there is various actions of alpha and beta over here. So there are two pathways. One is the uvascular pathway, one is the trabecular mesh pathway. So what happens is they both cause the emptying of the aqueous humor which is formed in our eye, right? So alpha 1 causes vasoconstriction of ciliary vessels and decreases the aqueous flow. Alpha 2 decreases aqueous secretion of ciliary epithelium. So overall, using the uvascular pathway, they are decreasing the secretion. Beta 2, they increase the aqueous secretion and facilitate through the trabecular mesh outflow. And overall aqueous formation is decreased. In GIT, both alpha and beta cause relaxation, right? Relaxation takes place of the GIT, peristalsis decreases and sphincters are constricted. Bladder, prostate and vas deferens. So detrusor muscle is relaxed due to beta 2 and beta 3. Trigone constriction due to alpha 1. Both oppose bladder voiding. So both oppose the emptying of the bladder in simple words. Vas deferens, what happens? Constriction happens of both vas deferens and seminal vesicles. So what happens in a way? They aid ejaculation, right? They aid ejaculation due to alpha 1, right? Alpha 1, they induce ejaculation. Next is the uterus. So in uterus, the adrenaline can cause relaxation and constriction. But in a pregnant uterus, what happens is adrenaline causes relaxation, only relaxation. We can talk about spleen also. What happens in the splenic capsule is adrenaline increases the blood flow in the splenic capsule, right? In the pulp, in the red pulp, the blood flow is increased overall. In skeletal muscles, constriction takes place due to beta 2, slow constriction of red fibers, and prolonged fast constriction and abbreviation of slow contraction. So it can also prolong the fast contraction and abbreviate the slow contraction of muscles. In CNS, adrenaline, it doesn't have much of the effect due to poor penetration of the blood-brain barrier, but may cause restlessness, tremors, right? And activity of alpha 2 in brain by clonidine. Clonidine is a drug, clonidine and guanfacine. They can be used in Alzheimer's, right? They can also be used in hypertension crisis. We'll discuss about this. Due to decreased sympathetic action, what happens is blood pressure decreases, bradycardia takes place, but after some time there is a reflex tachycardia due to decrease in the blood pressure. To compensate the low blood pressure, the blood pressure increases, but overall the sympathetic supply is there. That is why bradycardia is taking place, right? So these are the receptors where they are present. These are the action of the receptors. Now we will be studying a bit about biochemistry, and then we will study about certain drugs. So guys, let's learn a bit about the biochemical pathways. So what happens, we'll discuss about beta and alpha, right, on various other organs. So beta action through cyclic AMP, they activate adenyl cyclase through the GS protein, and there the ATP converts to cyclic adenosine monophosphate. So what happens over here, it causes phosphorylation, SCAMP dependent proteokinase, and activate the reaction. It activates a cascade of reactions. So basically the CAMP entering the cell or exiting the cell determines various other pathways. So here it is nothing but the G protein coupled pathway, right? So in liver and skeletal muscle, what happens? Glycogenolysis, right? Breakdown of glycogen. Hyperglycemia, due to which takes place, and hyperlactocidemia and gluconeogenesis or synthesis of new glucose molecules. That happens in skeletal muscles and liver, okay? What happens is when the liver is rich in potassium, right? So what happens initially, what happens, the potassium is increased, so hyperkalemia or elevated serum potassium level takes place, and it is decreased, it converts to hypokalemia. Why? Because the skeletal muscle take up all the excess of potassium over here. In adipose tissue, what happens is triglyceride lipase is activated, so increased free fatty acids in the plasma takes place, and this acts specifically on brown adipose due to beta 3 receptor. So brown adipose tissue is present more in infants, but in elder people it is present near the gluteal areas. In heart, what happens is troponin plus phospholambin, okay, right? They're phosphorylated, which what happens is the increase in calcium influx, and more of calcium is released from the sarcoplasmic reticulum, so that more of contraction takes place. Overall the heart rate increases. Positive ionotropic action by CAMP. So what does CAMP do? It activates the L type of calcium channel. We have L type and we have T type. So here L type is activated. Overall the heart rate is increased over here. GIT and lungs. So relaxation takes place, and due to hyperpolarization over here. Next is the pancreatic islet. So there is beta 2 action, but also there is action of alpha and beta together. So what happens is, there is action on alpha and beta cells of the pancreas, right? The islets, pancreatic islets. But overall, the beta 2 receptors are present in the pancreatic islets of the adrenergic drugs. The beta 2 receptors are present, but on the islets alpha and beta, what happens? Cell secretion increases by CAMP. Insulin secretion is decreasing. This is why all this is taking place. Or else cellular glucose uptake would increase, right? So insulin is decreased. G protein. Okay, so why insulin is decreasing is because the insulin receptors, they are independent of the G protein coupled receptors. So these are the action of beta on various levels. Similarly, we'll study what happens in alpha. So on smooth muscle, what is happening? Activates GQ protein. So what happens over here is IP3DAG inositol phosphate pathway is activated. Calcium increases. Activate the calmodulin. Calmodulin is a protein present in the smooth muscle. Calmodulin dependent myosin, right? So contraction will take place. Alpha 2, what happens? Increase in calcium without IP3. So this doesn't use IP3 pathway. It activates the GI, inhibits neuronal calcium 2 plus, that is it inhibits the calcium in the neurons, decreases CAMP, decreases noradrenaline, hyperpolarization by GPK plus channel. So hyperpolarization will take place due to GP, G protein P calcium channel. So hyperpolarization is taking place in the neuron, right? Overall over here, This is the action of smooth muscle. Let's talk about GIT specifically. This is alpha 2 and alpha 1. So alpha 1 and alpha 2 basically. So alpha 2, what happens? Hyperpolarization on the cholinergic neuron. Cholinergic neuron in the brain, right? Due to which acetylcholine is decreased, due to which the overall tone of the GIT is decreased. As we all know, GIT is controlled by enteric plexus, so there is no acetylcholine, so the tone is decreased over here. In alpha 2, what happens is, on smooth muscles, this increases the potassium efflux, due to which calcium dependent K plus channels cause relaxation. Calcium efflux, calcium is moving out of the cell, right? The cell is moving to its resting potential. In pancreatic islets, what happens is alpha 2 receptors, what they do is they cause the decrease of cyclic AMP, and due to which insulin is decreasing, right? Insulin levels are decreasing, so there is hyperglycemia over here. There is more of glucose in patient's blood, the cellular glucose is suppressed. Adverse effects and contraindications. So what can it cause? It can cause restlessness, headache, anxiety, tremors after subcutaneous or intramuscular injection. Blood pressure can increase, cerebral hemorrhages can cause due to increased blood pressure, or ventricular fibrillation and angina when given IV. Contraindicated in patients with hypertension and hyperthyroidism, because already metabolism is high and over here blood pressure is high. Overall, these adrenergic drug increase the blood pressure. Do not give during anesthesia with halothane. Halothane is an anesthesia. Avoid it. It's general anesthesia. Avoid it with halothane. And patient receiving beta blocker. So what happens is, here the upregulation of the receptors happen, due to which there is unopposed alpha action, and the purpose of the beta blocker drug is not solved, right? Either on the heart rate or on the blood vessels, it is supposed to decrease it. But what happens over here? Alpha is more active, so overall the blood pressure or the heart rate of the patient is increasing, and this can lead to sudden death. This happens when a patient who is being stopped from metoprolol, if he is consuming metoprolol 100 mg, it cannot be stopped to 0 mg after 1 or 2 weeks of therapy. No, it has to be brought down, because there will be upregulation of the beta receptors, which can lead to sudden cardiac death. So these drugs we will discuss about metoprolol, atenolol, labetalol, propranolol. These are very famous drugs. We will discuss about it. So guys, let's continue with few drug examples. So we'll start with alpha and beta adrenomymetics. What is adrenomymetics? The drug which mimic the catecholamines like adrenaline and noradrenaline. So adrenaline is the direct adrenomimetic and ephedrine is the indirect adrenomimetic, right? And ephedrine is non-selective. So alpha non-selective, that is noradrenaline. For non-selective drug for alpha, noradrenaline. For alpha 1, what it does is it increases BP. Example is phenylephrine. And alpha 2 is, it can cause CNS depressant. Example is napazolone, right? Napazolone causes CNS depressant. It is alpha 2 adrenomimetic and alpha 1 adrenomimetic, phenylephrine, which causes increase in BP. Now there is beta 1 and beta 2. So there is isoprenaline, which increases heart rate. Beta 1, dobutamine, which is used in dobutamine can be used to treat cardiac arrest, but it acts on the dopaminergic receptors, and it also has a few functions of the beta receptors. It is more effective on beta 1 compared to beta 2 and beta 3, right? But this is moreover of dopamine, and this also has DA receptor 1, dopamine 1 receptor. It acts on that. And beta 2, the selective drugs are salbutamol and phenytoryl. Salbutamol can be used in case of asthma attacks, as in inhalers they are used. So for asthma, salbutamol beta 2. So what happens? It is a non-catecholamine drug. It is a selective beta 2 agonist. Next is isoprenaline. This is non-selective beta 1 and beta 2. This can be used in case of heart block, specifically in case of AV block and for asthma, right? Then there is phenytoryl, which is a non-selective catecholamine, works for 4 to 6 hours, can cause premature labor. So what is this? This is an anti-tocolytic drug, right? Anti-tocolytic drug which causes strong uterine contractions. Then in case of cardiac arrest, as I told you, dobutamine, this acts on the beta receptor. It is a weak alpha agonist, acts on beta 1, beta 2 and beta 3, but more on beta 1 and dopamine receptors D1 specifically, right? This increases the cardiac output without change in the BP. There is no change in blood pressure, but overall cardiac output is increased because it changes the systolic and the diastolic pressures, right? But there is no change in the BP, please remember that. In case of heart block, we use ephedrine, which is MAO resistant. This doesn't depend upon monoamino oxidase. Ephedrine doesn't depend upon monoamino oxidase and is used in case of AV block. AV block. We can use this, or we can also use isoprenaline. In case of heart block, specifically AV block. Next is for anaphylactic shock. So what happens is we can use adrenaline. We know adrenaline is a physiological antagonist of histamines, right? So adrenaline is the best drug of choice for anaphylactic shock. And talking about noradrenaline, if we give an injection directly IV, it causes necrosis of the surrounding area and the injection is very painful. So the injection is not given IV, right? For hemorrhagic shock, we can use phenylephrine. This is an alpha-1 agonist, increases blood pressure by vasoconstriction. We can also use clonidine and guanfacine, which is used in hypertension crisis. The alpha action in CNS decreases heart rate as well as BP. Peripheral alpha-2 action decreases the sympathetic supply, hence the cardiac output and heart rate and BP decreases likewise. And also these are good painkillers, they can reduce pain. For hypotension, you can use phenylephrine again, which is an alpha-1 agonist, right? Alpha-1 agonist. If somebody is suffering with hypotension, you have to increase the blood pressure. So as I told, this causes increase in blood pressure, vasoconstriction. Next, for allergic rhinitis or literal nose block in simple words. So what happens is there is vasoconstriction over there, right? There is vasodilation, we have to constrict the vessels. In allergic rhinitis, there is vasodilation, we have to constrict the vessels. So we use nafoxylin and halozylin, right? They are the best drug. They are used as spray. You might have seen in advertisements as Otrivin. Alpha-2 agonist, they act for 12 hours, but the side effect is they cause CNS depression and increase in blood pressure. Hence, it is contraindicated in patients taking MAO, monoamine oxidase inhibitors, and hypertension, because they can further increase the blood pressure. And monoamine oxidase inhibitors increase the action of these drugs. They don't let the reuptake of the noradrenaline, hence the action is overseen, right? Hence it is dangerous in patients. For example, for this MAO inhibitors can be aminoglycosides antibiotics, right? One of them can be aminoglycoside antibiotics. So with this is a wrap for adrenergic drugs. In next we will discuss about anti-adrenergic drugs. It is a simple chapter but with a lot of drugs. And for now it's a wrap. Thanks for watching the video, and do like, share and subscribe, and stay tuned for further more videos. Thank you.